Good afternoon, everybody. I think we're going to get started. It's 1 o'clock. So I just want to say welcome and thank you to all of you for joining us today. We're going to discuss best practices for the transition of care between nursing homes and dialysis facilities during the COVID-19 pandemic. We would encourage all of you to really have transparent communications amongst all care partners. We encourage you today to share best practices in the chat, and we also encourage you to put all questions in the chat. All of our lines have been muted. We have quite a few people on this call today, so we will not be able to unmute all lines. There's just too much background noise when we do that. So we would, again, encourage you to share your best practices in chat and any questions in the chat, and then we'll compile those and we'll discuss them at the end of our presentation today. So again, thanks for joining us, and we're going to get started. Just some reminders, please be present and engaged in our topic today. Again, any questions you have, please put them in the chat or the Q&A throughout the webinar, and we also encourage you to add any best practices that you have uncovered in your facility. And again, the slides will be shared. All the slides will be shared at the end of the webinar, and they'll be posted on our website for anyone to review. Best practices, again, please put those in your in the chat today so that we can compile them and discuss them at the end of the meeting today. Some key areas that we'd like to improve is dealing with facility changes and transportation with COVID, discontinuing transmission-based precautions when testing strategy is not an option to confirm negative results, and assuring transportation is safe and available for all of our patients. This is myself, Sue Swan-Blum, and Deb DeWalt. Deb's the Quality Improvement Director. I'm the Quality Improvement Coordinator, and together we make the Quality Improvement team here at the network. What is our network role? The networks are partners. They are partners, and we work together to achieve critical bold CMS goals and transform healthcare. We also address the aims of the National Quality Initiatives and the priorities of the Secretary of Health and Human Services. We are a contracting agency, an organization funded by the Centers for Medicare and Medicaid Services to improve the quality of care for individuals with end-stage renal disease. We work with families, patients, care partners to provide transportation, and transplant centers and other stakeholders to promote patient and family-centered care. We support access to appropriate care for all end-stage renal disease patients. We promote best practices. We improve patient safety, and we assist with emergency readiness and disaster relief for the ESRD population. There are 18 end-stage renal disease networks in the country. IPRO is the company we represent. We have 4 of these contracts. We have Network 1, which is the New England states, Network 2, which is New York, Network 6, which is North and South Carolina and Georgia, and Network 9, which is Ohio, Indiana, and Kentucky. Network 9 is the end-stage renal disease of the Ohio River Valley. We have approximately 35,000 patients. We take care of 651 dialysis providers and 14 transplant centers. Now I'm going to turn this over to Deb DeWalt, and we're going to start with the objectives today.
Good afternoon. The objectives for this program really are as follows, but the ultimate goal is to improve dialogue between nursing homes and dialysis centers, and to assure that a smooth transition of care is underway when we are dealing with patients that are COVID positive or under suspicion for being COVID positive. At the conclusion of this presentation, we hope the learner will be able to identify some best practices to prevent virus transmission, improve communication and screening and triage processes, list the 3 isolation tactics in place within ESRD facilities and regions to control infection, discontinuation of transmission-based guidelines, discontinuation of transmission-based precaution guidelines and current processes, and list the network resources that are available for ESRD patients to assist with transportation and other issues. Next slide, please. The best practices we have gathered are going to be presented in the next section. Next slide. So best practices we have gathered to prevent droplet transmission of the COVID-19 are based on social distancing. And we have learned these through our conversations with dialysis facilities and other stakeholders. But it is a good thing for the nursing home care partners to know, so they may be best able to educate their patients or residents, families, and the residents themselves for some of the alterations in care. Most group waiting rooms and dialysis facilities are closed. Very frequently, chairs have been removed. If they are in place at all, they are in a distance that maintains a minimum of 6 feet. Patients are mostly been instructed to wait in cars or their transport vehicle until they are escorted in for their therapy. No visitors in facilities, which also includes transport unless absolutely mandatory. Patients are separated by a minimum of 6 feet at all times in dialysis facilities. Patients are masked upon entry to the building, and the transportation provider should also be masked or offered a mask if they do not have one. Sinks and hand sanitizer are readily available to patients and staff, and all caregivers are notified of COVID status and provided appropriate PPE. You will see that some of our patients, which we'll discuss later in the presentation, are going to alternate care centers that are cohorting like status COVID patients together. So the level of PPE will be dependent on the patients being treated. Dialysis facilities are cohorting patients in a like area or a common facility based on COVID status. Next slide. To reduce aerosol transmission, we are masking all patients, staff, visitors, vendors, anyone who enters the building while they are in a dialysis facility. The mask will remain in place throughout the patient's treatment and while the patient's staff is in the building. Staff will utilize the appropriate mask when caring for patients depending on the COVID status of the patients they're caring for. Testing swabs will be obtained in an isolation area. We cannot test for COVID in the treatment center itself. If a patient needs to be tested while they're at the dialysis facility or before they leave the dialysis facility, many dialysis facilities have established tents outside with specially trained patients. I learned today that one center is actually doing drive-through swabs for patients within their region. And if those two are not available, the patient needs to be swabbed or tested for COVID in a controlled, sealed isolation area, which is not being regularly used and can be terminally cleaned after the test is performed. We ask that all transporters wear masks, and if the facilities if they enter the facility, they need to go through the same screening process as all of our patients and staff. Transporters, once again, should be offered the appropriate PPE if none is available to them. Next slide, please. To reduce contact transmission, some of our best practices are based on theories and research that have demonstrated the coronavirus can live up to 24 hours on cardboard and 72 hours on plastic and stainless steel. Some of these best practices are what we've always practiced, and what we always hope is happening is hand hygiene is performed at each point of transition of care. So before the patient leaves the residence, before they enter the facility, before they are transported back to their residence, and at the time they're received at their residence. Cardboard packaging in facilities is strongly recommended to limit the amount of packaging in the facility. If it's impossible, cardboard should be wiped down. Patients are given wipes to wash transportation services. So if they are going on a bus, a multi-patient transport, they should have wipes to be able to wipe down their seats, the door handles, and hopefully, if at all possible, to maintain a 6-foot distance between patients. Frequently scheduled cleanings of surfaces are occurring within the dialysis facilities, and these are sometimes maybe delaying treatments a bit, because all hard surfaces must be disinfected. And these common surfaces, for an example, are doorknobs, phones, keyboards, countertops, etc. Any shared durable medical equipment such as wheels, wheelchairs, Hoyer lifts, transfer boards, oxygen concentrators, blood pressure cuffs, and thermometers all must be wiped down between patients. The recommended dilution for an approved bloodborne pathogen disinfectant that will kill the coronavirus is 1/3 cup of bleach to a gallon of water, and this is for a topical disinfection. Next slide, please. So what we really want to promote with this webinar is that we want to improve the communication that occurs when we transfer these vulnerable patients between care entities. And really the best culture to develop is when you have anything to report regarding a patient's COVID status, their suspected status, or pending testing, that we need to develop a culture of call ahead. This needs to be bi-directional communication. Next slide, please. Some of the terms that you'll hear that we're using very frequently are from those that are defined by the CDC. One term is quarantine. Quarantine is used to keep someone who might have been exposed to COVID-19 away from others. This person is often termed a person under investigation or a PUI. There are many regions of our network in Ohio, Kentucky, and Indiana who have specified special units or shifts to cohort patients who are waiting for testing to be completed, or in the absence of testing, go through the amount of time that they need based on CDC guidelines to be considered free of suspicion. Isolation is used to keep sick people from healthy people. So people who are in isolation should be staying at home. They should be sequestered from others within the home or residence by staying in specific sick bedroom or a specific sick hallway, and use different bathroom facilities if possible. We have learned from some of our nursing home partners that they have also joined in the same practices that the nursing home, that the dialysis facilities are doing, where they are cohorting patients who are COVID positive in either one part of the nursing home with the same staff providing care, or else they have actually established cohort nursing facilities or long-term care residences. So the term isolation, when we use it, we are talking about patients who do have a COVID positive diagnosis. Next slide, please. So what are we doing when we screen for patients? And your patients may be talking to you about this when they come back to the nursing home, but we're determining the isolation or quarantine strategy for each patient. Some of our patients will have no symptoms of COVID or persons under investigation, and will go into the general population of the dialysis facility. Yet those patients, even passing through screening, will all be masked. COVID strategies are really been whittled down to about 4 different determinants. One is that with COVID positive symptoms, with symptoms, COVID positive without symptoms, persons under investigation with symptoms, person under investigation without symptoms. And you will see that different patients will be sent to maybe one isolation unit, but at many different times of the day, because they're using these strategies to cohort like patients together. These strategies are going to require a lot of communication, because not only do we need to know the symptoms to best prevent transmission to patients and staff, but we need to make sure that the patient understands why they're going to a different facility at a different part of time or different times of day. And possibly we need to make sure that their families understand that as well. And definitely communication needs to be done with the transportation companies delivering these patients for care. The symptoms that we are looking at in our screening, actually these have all been updated within the last week. We used to just look for cough or sneeze, shortness of breath, fever, general malaise, loss of smell or taste, but now these have also been expanded to include nausea, vomiting, diarrhea, and headache, and also muscle pain. Those are the new updated symptoms from the Centers for Disease Control as of, I think, Friday afternoon. But transparent communication has to be completed prior to transferring patients so that everybody who is invested in the care of the patient understands what is necessary as far as PPE, quarantining, isolating, and making sure that those strategies are in place before a patient arrives at a dialysis facility and is told that they can't dialyze at that particular time of day because we're going to have to move you to another facility because you have just told us you're COVID positive at your nursing home. So I just want to make sure that this is done both directions. At the time the patient leaves the building, at the time the patient starts their therapy, and when they are received back to the nursing home as well, or when they are sent from the nursing home. It's very important that every partner knows the COVID status. I know that we have seen that sometimes patients are sent and the nursing home or even the dialysis facility does not know the COVID status, and maybe even the patient shares their COVID status. So we just want to make sure that this is bi-directional and all communications are shared between partners. Next slide. So the call ahead culture is really some of the best practices we've just already sort of gone over, but the care partners on both end of receiving and delivering a patient to another center should have a preemptive screening plan. So prior to loading a patient in a van to go either to the nursing home or the dialysis facility, the patient should have been screened using the CDC symptoms, and a temperature should be measured. When we when we send the patient back to the facility, we are also measuring temperatures and checking for like symptoms. A phone call should be made to any receiving entity to communicate any symptoms that are identified in triage. This can prevent a lot of trouble for the resident and the dialysis patient, because it may not be appropriate to send the patient to that particular center for treatment at that time if we know that they have symptoms that categorize them as a person's under investigation or somebody who is awaiting testing for COVID positive. Not only should dialysis centers and nursing homes share communication between one another, we also need to make sure that the people who transport these patients are aware of the screening that is taking place and what the patient's status is prior to sending them on the van or the ambulance to therapy. If the transportation company has not provided PPE that is appropriate for the level of care for the patient that they are transporting, that PPE should be offered to them. Next slide. So what would you expect to see regarding dialysis patients? Well, many dialysis facilities, large dialysis organizations, are cohorting patients with light status, and they are isolating these patients from the general patient population. So dialysis facilities have really very rapidly put into place 3 strategies to isolate and cohort these patients. One is most frequently seen in larger metropolitan areas, and that is a regional cohorting facility where they centralize one facility that assists with these COVID positive or patients under investigation, and they separate them on shifts. There are no other patients that are not of the same status treating at the same time. This helps assist the large dialysis or independent facility with staffing, PPE allotments, and the increased patient care that some of these patients may need. And it also assures social distancing requirements are being met between patients. The patient and family and nursing home caregivers need to be notified of the need to reassign a patient to a new dialysis facility as soon as possible, so planning can begin for a smooth transition. I can't emphasize enough that it really needs to be known to the patient that we're doing this for their protection and to keep them in a care center who is specializing with people with their diagnosis. I heard the terms clean and dirty facilities being used, but all of the facilities are equally as clean and following all of the state recommendations for sanitization and environmental cleaning. It's just not a good term because they don't understand that they're going to a place where they can get the best care. Sometimes when they go to these regional cohort facilities, the day and time of treatment needs to be altered to accommodate the cohorting, and obviously transportation adjustments need to be made to get the patient to the new location and time for that COVID status patient. Next slide, please. The second strategy is if the patient remains within the current dialysis facility, they may be cohorted on a later shift to accommodate isolation. This is very frequently done in areas where there is no cohort facility available within a reasonable amount of transportation time. They're treating COVID and PUI status patients generally at the end of the day to provide for a terminal clean. These shifts are usually started about 30 to 45 minutes after the last general population patients have exited the building. And this really does provide for more room and time to provide for social distancing and allows the patients to have the facility's terminal clean after the patients are vacating the building. Less frequently, if the patient is going to stay in their facility, they may do so, and they may have to alter the time or day of the week if they are going to dialyze in an available isolation station. If they are dialyzing in an isolation station, which is generally a glassed-in room or a chair at the end of the dialysis water run, further away from other patients, they need to make sure that there is the station that they're working within in the isolation station has not been utilized for hepatitis B. And this really only supports 1 to 2 patients. So this is a very limited strategy for cohorting patients. Very frequently, facilities don't like to use their isolation room because it still means that the patient has to walk through the general population to get to that isolation room. But these do give options for rural units or facilities that would require transportation of the patient to a very long distance to the cohort facility. So what I would like to stress with everyone involved is that when you are altering a care plan to accommodate isolation or quarantine for people who are COVID positive or determined to be a person under investigation, we alter these treatment plans with physician's orders, and that they are based on lab work and physical assessment. So while it is not always done or not frequently done, patients can go from a Monday to a Thursday, Saturday to complete their 3 treatments. Or they could have a Tuesday, Wednesday, Friday treatment to accommodate these 3 treatments. We do expect to have patients rescheduled and for care as soon as possible. And we, as a network, do assure access to care for all dialysis individuals. Go next slide, please. So when do we take a patient out of transmission-based precautions? When is the patient who is COVID positive considered ready to go back into the general population? When is the person who's under investigation ready to go back into the patient population? CDC has delivered guidelines based on isolation, release of isolation for dialysis and outpatient facilities, and I'm going to share those with you on the next slide. I'm not going to go over all of this because there's a nice synopsis on the next slide, but this is the CDC guidelines for discontinuation for transmission-based precautions for COVID-19 patients. There are 2 strategies. One is if you are using a test to release a patient from COVID positive situation, and that would be the result of preferably nasopharyngeal swabbing done 24 hours apart with 2 tests, and also the resolution of fever and of respiratory symptoms. In non-test-based strategy, there should be 72 hours have passed without any analgesics required to relieve fever and the improvement of respiratory symptoms, and at least 7 days since the symptoms first appeared. If the patient is discharged to home, until they are released, they should isolate and be followed by state and local health departments for the 7 days since symptoms appeared or a positive test was received. If they're discharged to a nursing home, they should be placed in an area specific to the care of COVID positive patients and wear face masks during the time of direct care is administered during that 7-day window. Next slide, please. So once again, the minimum criteria are basically 72 hours for fever and the reduction of respiratory symptoms or improvement, and 7 days since the appearance of symptoms. One thing that we really want to stress, and we've seen a lot when we're calling dialysis facilities, that patients are remaining in the hospital because they cannot get testing done. Hospital release, and CMS is very clear on this, should not be dependent on isolation release. Patients can go back to a residence or home and await their 7 days out, and they do not have to wait in the hospital. Now, these timelines are the minimum timelines, and timelines we have seen have been increased by local and state health departments or even individual care partners protocol. So you can't go less than these guidelines, but you can always increase these guidelines timeline. So one of the things that we want you to take away is that communication is mandatory. And I think that we should all meet with our teams after this presentation to determine if we do know how long isolation should continue and what are the patient's status and how do we communicate with one another to make sure that the ESRD patient, some of the most vulnerable in the population, are being cared for appropriately and they're getting good care in both transitions between the entities. Next slide. Sue's going to talk to you now about some of the ESRD resources that the IPRO ESRD network program has been constructing and that are available on our website. And I think these may be very, very interesting and useful to you.
Challenges from transportation during COVID-19 and in some of the really hard-hit states, we set out to connect with our state departments of Medicaid, Job and Family Services, emergency management agencies, and community organizations to compile information on the management of transportation. We created resources for facilities to help them problem solve transportation issues for patients. I mean, the pandemic has caused some closures of transportation companies and some issues with COVID transport patients to and from the dialysis unit just because of lack of PPE. So by doing an environmental scan of the state directives and emergency orders, we were able to put together a step-by-step guide to secure alternative transportation options for patients tailored for each state. So these resources are posted on our website for review. They are currently still in draft status, but we did feel that the information was very good and it was something that we needed to get out to the community. So, but these are in our graphics department to, make sure they're appropriate for distribution. So these are currently in draft status, but really take a look at them. They're on our website for review. Now, the state transportation databases. The transportation is evolving. It's, definitely a live entity, and it's impossible to capture all the changes in one resource flyer. So our patient outreach coordinator, Laura Rodriguez Cabon, has compiled and developed 3 databases, one for each state, and they are searchable by county. The network keeps a running list of information and additional resources facilities can use to secure alternate means of transportation. We've seen some really creative things too in certain counties they're doing to address these issues. They've looped in the senior centers who provide transportation with their buses to dialysis centers. Public transportation authorities filled in the gaps by setting aside some buses for specific patients. So these are just a couple examples, but these databases are also on our website. They are by state. You put in your county and it gives you a field of search, and then it gives you some alternate transportation to take a look at. In connecting with emergent management agency, it became really clear that additional education about acute needs of dialysis patients and the importance of transportation for this population was needed. This document, again, was created by Laura, utilizing emergency management agencies and State Department contacts to think creatively to address and solve issues using best practices in the emergency transportation plan. This is just a quick reference guide to address some of these issues that can be found, and it is also on the network website for view. Again, it's in draft status, but we thought the information was important and we wanted to get this out to everybody. This is our website where everybody can, this is the website address. We have very good comprehensive resources for both professionals and patient resources. We also have now initiated a 24-hour hotline for COVID-related issues, and that number is also posted on our website. So please take a look for any additional resources you might like. These are some of the things we do here at the network. There are these 3 flyers that were developed for patients. One, urgent reminders, just to tell the patients really don't miss your treatment, how you can follow CDC guidelines, emergency diet plans just in case, what are the signs of the coronavirus, just really good facts for the patients to learn and know about the coronavirus. Transportation tips, what they can do to make transportation safer. Deb touched on a few earlier where they could, try to sit 6 feet apart, stay in the house until you get into the transportation, cover your face while you're in the transportation vehicle, use wipes to help sanitize, all of those, really basic reminders, and it's all on a 1-page sheet to give to the patients. This is also all available on our website. Then there's also an informational sheet about telehealth. Is being utilized really pretty extensively now for visits with a physician, visits with your nurses, to really sort of get in touch and communicate without leaving the house. Patients are pretty scared in this environment. They already know they have a chronic disease, so they are very cautious, and this helps them keep in touch with their providers. The network also pushes out emergency messaging every week, including new updates from CMS and the CDC. It also includes network resources, how to get in touch with us, just pretty much any new and updated information. So that goes to each and every facility. It goes to facility managers. It goes to social workers. It goes to medical directors. Additional resources of obviously the Centers for Disease Control. They have a COVID-19 page. They Centers for Medicare and Medicaid Services. They also have a COVID virus partner toolkit. All good resources. We have the Kidney Community Emergency Response Team, or CASER. So there is another place for good and excellent resources. There are also some resources on here that were created by patients and made for patients. So another really good source of information for patients. There are also, each and every state has a website where they have a COVID-19, where they give numbers and additional resources and information by state. We want to thank you very much for joining us today. Let's make a little bit of an apology for us. We're doing this in many separate locations where we usually sit in the same room. So And we want to go over with you now anything that's in the chat and our best practices that we hopefully could share and amongst all of us. And I'm hoping I'm going to turn to Vicki because I cannot see the chat. So I'm hoping she can put those in for us. And if there are any questions, then we can get those answered.
Sue, there one best practice that came up early on in the conference was one of the healthcare providers said that their county is actually hosting a call between all healthcare settings in their county and discussing, issues and barriers and really problem solving with a group of healthcare providers. So that would include dialysis facilities and nursing homes and hospitals and I'm sure other clinics. So I thought that was a really exciting best practice and a great idea because usually the resources are local. I haven't seen any other come through lately. I can go back and do a scan. I tried to keep track of that all the way along. Deb, did you see any others coming in when you were looking?
I did not, but one of the things that I learned today when I was doing some of our best practices calls with facilities was that some nursing homes were actually cohorting like status patients together and transferring them temporarily to cohort nursing homes, which is something that I learned that was new. That is definitely a strategy that might be attempted in areas with large nursing home populations in the community that have COVID positive diagnoses.
Well, that's a great strategy to hear about. We had not heard of that yet. I'm not aware of any other. I tried to check both questions and chat. There was a question that was raised about patients reporting if they find their status out, some situation outside of the clinic setting. And yeah, absolutely. Our outpatients are required to report that. That's a matter of public health safety. And, anyone who receives a positive diagnosis is supposed to let people know. And, in particular, a clinic where there's great risk for transmission of the disease. So I just wanted to say that one question out loud. Other than that, I don't think we have any other questions that I've seen.
And we're very, very excited to share this with you today and create a great partnership between the dialysis facilities and the nursing home population, that we both serve these very vulnerable populations. And it would be great to have this be an entry into further communications and presentations. And we would accept any ideas from our nursing home care facilities for further education that they may want or need that we could provide.
Oh, I did pick up on something in the Q&A. I just came in from one of our social workers in dialysis, and it's in regards to ambulance and ambulette transport, paratransport. So she's asking if, does this mean Medicaid will be paid for COVID positive patient ambulette trips if positive, even if the person is ambulatory? And yes, my understanding is there's an FAQ that has been released by CMS that speaks to the fact that the nature of the illness for an ESRD patient who needs transport and is also COVID positive is such that they will approve ambulate or ambulance payment. We're still trying to get the language a little better worded out from their FAQ. That's something that some of the national level ESRD groups are working with CMS on, but I can direct you to that FAQ that came out that speaks to the reimbursement for transport of a positive patient to ambulances or ambulance. And I think her other point here is that are sometimes cohorting skilled nursing facilities are sometimes cohorting patients, putting patients in isolation upon admission for 14 days. Automatically, others have different PUI requirements, release criteria than dialysis. So sometimes patients are in isolation with the SNF and not at the dialysis. And yeah, we've heard all those variations, Madeline, and I agree. I think probably the 14 days when they do new admissions is not a bad idea just because they don't know that person's background. many of those patients may be poor historians, and it's probably a good safety piece. But there are different levels of releasing people from the isolation discontinuation. One of the things we were trying to get across with this presentation is that each group should talk to each other, because if we're not isolating at dialysis, but the nursing home is, it probably isn't helping the nursing home. So maybe we need to come to some middle ground on that. So great points by Madeline. I know she works with a large patient population out in the Northwest Ohio area. So thanks for sharing.
There's one other question, and it's directed, I guess, regarding where the patient tests. So if a patient tested positive outside of the clinic, and you could also extend that to nursing home, are they required to release that information to the clinic? Yes, they are required. And when they are coming in for screening, that should be included in your screening as to whether you've had exposure or knowledge of a COVID positive diagnosis for yourself, your family member, or your care partners. So yes, that is required, and it should be something that is trained to all patients during the screening process, that they need to let us know ahead of time, preferably calling first. And that goes along with that call ahead culture. It isn't just for care partners, but it's also for patients that they should call in advance. I think that concludes our programming today, and we're very privileged to have all of you with us, and we bid you a great afternoon and hope you could get outside and look out the window and enjoy that beautiful sunshine. Good day. Bye-bye.